So I want to welcome you to our Dairy Goat webinar series. My name is Jennifer Bentley, and I'm a dairy field specialist with Iowa State University Extension and Outreach. And this is part of our educational series on dairy goats. Right now, we are under a USDA grant, Sustainable Dairy Goat Agri-Systems. And so this work is being supported by that grant. And so this is the second webinar of our series. Today, we're going to be talking about neonates and that first critical 24 hours. We know that's a particularly important time of that dairy goat's life. And particularly for many of us right now, we might be entering into that kidding season. So this is a very timely topic here. I do want to remind our audience as well that this is ARPAS approved. So if you need some continuing education credits, you can certainly get those for tuning into this webinar here. And then also our upcoming webinar is going to be on March 19th, where we'll have Laura Kaiser from Dairyland Laboratories talking about testing and evaluation utilizing your feed test results. So happy to have with us Dr. Rachel Friedrich. We had her on our previous year's webinar series, and today she's going to be talking about the neonates. She received a BS in Ag Sciences, majoring in animal science from University of Nebraska, Lincoln, followed by a DVM from Iowa State University College of Veterinary Medicine. And currently, Dr. Friedrich is a senior clinician and a section head of the Food Animal and Camelid Field Services Unit with a focus on providing veterinary curriculum instruction and professional services in small ruminant and bovine medicine and surgery. So thanks for being on our webinar here today, Rachel. And with that, I'm going to stop sharing my screen and you can take it away.
So hopefully you are seeing Neonatology, the critical first 24 currently. Okay, right. Jen, thanks for the introduction and thanks for everyone for being patient. I'm pretty solidly booked this week, so jumped on a little bit late, but I appreciate the chance to join you all today to talk about neonatology. We're going to actually focus on three different areas of neonatology today. Hopefully it will advance for me here. There we go. Okay, so our three areas of neonatology that we're going to focus on today are the prepartum period in the doe, resuscitation of neonates, and some considerations there, both physically and pharmaceutically. And then finally, the always timely topic of colostrum. So I'm not going to go as in-depth on colostrum today as we could. There's been a couple really good webinars that have been presented over the last 2 years as part of this webinar series that are available on the extension website. Maybe, Jen, if you get a second, you could drop those links into the chat box. They're very good overall overall looks at colostrum, and I highly recommend everybody to take the time to listen to those again, but we'll touch on the high points that way. So jumping into the prepartum period. So what we do to the dam has a significant impact on the fetus. I think anybody that's been through a drought year where our forages weren't as great as we would like them to be understands what we call fetal programming in research is a real thing. So from the time that they're conceived until birth, the care that we take with our dams has a significant impact on the kids themselves. And so one of the questions that I often get is about vaccine boosters. So how do we use vaccine boosters in our dams in order to protect our kids? When should those be given? What's the timing behind that? What if I forget or I don't get it done as soon as I should? Realistically, what we're trying to do with these vaccine boosters in the dams, especially on the clostridial disease side, so like Clostridium type C and D, and tetanus or a CDT vaccine, is for protection in the newborn kid. So when they're born, they don't have any immune response immediately. They have no protection. We're relying on our colostrum to do that. In order for that to be effective, we actually need to vaccinate the dam 4 to 6 weeks prior to parturition to allow her body time to respond to that vaccine, develop the IgG antibodies, and then actually put it into the colostrum when colostrum is being formed in the udder. So our colostrum starts forming as early as 3 to 4 weeks prior to parturition. So if we're not getting our vaccines in ahead of that, we're missing that window. This typically includes those clostridial vaccines, but we're also seeing more and more use of the mastitis vaccines for Staph aureus in our dairy goats. That one's more for protection on the doe than it is on the kids, but the timing's about the same there. Even in the dead of winter, we still consider parasites as part of our overall health plan for our dams, because if they're carrying a very heavy parasite load, that's another draw or another energy suck on the body that they're then not able to put that energy into growing that fetus. So don't forget about doing your Fibonacci scoring, your fecal egg counts, and your overall parasite management plan, even on those late gestation does in the dead of winter. We're also going to touch a little bit here on nutrition in terms of the body condition scoring and how we're balancing some of our rations in order to keep our energy content where it needs to be for our does. So ideally, we want to have those does at a 2.5 to a 3.5 at the start of the breeding season. And we want to maintain that throughout the entire pregnancy. And so at minimum, we want to be reassessing body condition score halfway through gestation. That's because the fetus does the majority of its growth, its weight gain in that last third. So we're going to start drawing a significant amount of energy off those does in that late gestation period. We want to know at that halfway point that we're in the right plane of nutrition and the right body condition score. Just as a reminder, the doe that's up here on the picture right now this is from the ADGA Dairy Goat Body Condition Scoring document. This is a 3. We're looking at that shoulder blade. We're looking at those hooks and pins and the level of coverage that's over those. So we don't want those fat does that have excess cover over their tail head area and their hooks and pins and along their ribs. We also don't want to be able to see those ribs standing out from 10 feet away, right? So we want to feel them. We don't want to really see them excessively to know we're in the right condition. That late gestation nutrition is critical for both fetus and fetal growth and also for the dam. Why it's critical is because our energy needs increase exponentially in late gestation. If that doe is carrying twins, her energy needs go up 180% over maintenance. If we go to triplets, we're into the 220 range. If we get into quads, it goes up from there. Add to that a lot of times our late gestation is during a time of year where weather is not ideal for us. And so we've got these extreme cold periods in the Midwest and even in other areas of the country this year that we're dealing with that increase the energy needs of the doe. When we expand that uterus with growing fetuses, that also reduces the overall abdominal capacity. Those babies are taking up more space in the abdomen, which means the rumen can't fill as significantly with feed. And all this results in them just literally not being able to eat enough to meet their calorie requirements. So they end up in a negative energy balance. When we consider what our forage does to that energy balance, it's all about the neutral detergent fiber. So that NDF or neutral detergent fiber content of the forage drives the overall feed intake. So if we have high NDF feeds, those are your higher lignin content, more STEMI, more coarse feeds. That are going to take longer to digest for those animals. So that means that they're not as hungry. They don't eat as much feed. So their feed intake goes down to also those high NDF feeds tend to have a much lower energy content in general, lower protein. So that pushes us further into that negative energy balance. So the biggest bang for your buck here in those prepartum does is to test those feeds and especially the forages. So it's awesome that we're doing this webinar next month about feed testing because that is a key component to being able to actually balance the ration for that neutral detergent fiber. If you are using a free program or the NRC guidelines in order to do your ration balancing, just note that NRC actually overestimates what those does can physically intake. And so it's kind of thinking that the does are eating more than than research actually shows us that they are. So some of those free programs are overestimating that intake, and thereby they're actually overestimating the calories that they're getting in the protein. So just for a comparison, these are a couple hays that I tested 2 years ago. One of them was a mid-season mixed grass hay, and the other was a second cutting alfalfa. So we typically like to think of our alfalfas as being better quality feeds, mostly because of higher protein levels and higher sugar or carbohydrate levels. But one of the big differences between these two is actually in the NDF here. So my mid-season grass hay is pretty typical of a grass hay in the testing that we often run, and it's roughly, NDF runs roughly about 60%. Contrast that to that second cutting alfalfa where we're down in the 40s. So our alfalfa is a much more digestible hay here than our mixed grass hay. And if we figure that our maximum intake for on an NDF basis is around 0.8% for those late gestation does, if we got a 150-pound doe, she's actually going to eat almost a pound more in that second cutting alfalfa each day on an intake basis, on dry matter basis, than she would on the mid-season grass hay. And so that's a significant amount of calories and protein that she is going to take in from that alfalfa that she's not getting out of that grass hay. I wouldn't know this for sure if I hadn't done this feed test, but if I have to pick one, I'm going to use that nice alfalfa in my late gestation does, because I really need a good concentrated nutritional feed source for those does that can't eat as much. Vitamins and mineral requirements go up in late gestation too. We've got this fetus or fetuses that are growing rapidly. There's big baby bones that are developing in there. And because of that, it takes more calcium and phosphorus for those bones to develop. So if we have does that are on the borderline of being sufficiently supplied with calcium and phosphorus to begin with, we may actually see some prepartum hypocalcemia or some prepartum milk fevers starting. Our DCAD diets can help us with priming the bones to actually release some of that calcium that they're storing and help prevent some of this. But again, this is another good reason to do a ration analysis and balancing. When we start talking about vitamins and our micro minerals, vitamin A, D, and E, unlike our minerals, don't cross placenta very well. So they have a tendency to be very poorly transferred to the fetus in utero. Instead, where our neonates are getting that vitamin A and E, especially, is through their colostrum and milk. So kids that are being born weak or not getting up and nursing or not taking in good quality colostrum are also going to end up being deficient in that vitamin A and E, which perpetuates the weakness. Typically, our stored feeds are going to be more deficient in vitamin A and E than our fresh green grass. So if you're kidding in June on very nice fresh grass, you're probably not seeing this A and E deficiency. But if you are having kids that are born in late February and have been fed stored feeds for months, we might be seeing some muscle weakness in those kids because of vitamin E deficiency, especially. With that, a lot of times our nutritionists are supplementing excess vitamin E into the ration to help counteract this, or we're even using some injectable products in the kids or does when we're seeing a lot of problems with it. That's something that you work with your veterinarian to define and develop a treatment protocol for. Selenium is another big one that we often see implicated in weak kids or kids that are not starting off well, does that are becoming retained placenta, and things like that. Generally speaking, you can see here on the map that's on the slide, most of the United States is at least selenium sufficient. We might even be in selenium excess in some places. Where this comes into play, though, is selenium and vitamin E are cofactors. They work together. So if we have vitamin E deficiency, we may still see some of the same disease, even though our selenium is adequate. Doing liver biopsies or retaining liver samples from animals that have been sent to slaughter can be a way for us to look at the overall selenium status in our herd and whether or not we need to supplement. For prepartum energy requirements, I'm sure everyone that's joined us on the call today has seen or heard a lecture on pregnancy toxemia. In the past, the Dairy Goat webinar series had Dr. Andrea Mangini on talking specifically about the syndrome of pregnancy toxemia. And that there are two different pathways to this occurring. We kind of see two different syndromes with preg tox. The first one being that fat doe that develops ketosis. Essentially, she goes into a negative energy balance, and her body starts to metabolize and mobilize that peripheral fat in order to get it processed by the liver into volatile fatty acids, which are also known as ketones, which can be used as an energy source in ruminants. So what it's trying to do is make up the energy requirement by breaking down fat. That can actually overwhelm the liver and then cause a liver dysfunction. And there's lots of body processes, everything from energy production to proteins, to detoxification of the blood that happens with the liver. So when we start to have issues there, we see it progress really quickly. So that's the first one. The second one is the thin does, so the underconditioned does that don't have that body reserve, and those that are having litters. So we're talking the triplets, quads, quints, and on up from there. Those does just have such an extensive draw on their energy requirements. Those fetuses are taking up all that blood glucose. So their blood glucose drops and they get hypoglycemic, they get weakness, they stop eating, and it becomes a cycle. So regardless of which type of pregnancy toxemia your doe ends up in, both situations result in a higher level of ketone bodies that suppress the appetite, and then they end up with a blood sugar where it's either too low or it's high and we can't use it, and so they're weak and they're having more physiologic problems because of that. In the early stages of pregnancy toxemia, we see lower limb swelling. So their blood proteins become low. So their overall total protein, their albumin drop, and they end up getting fluid retention and swelling in the lower legs. These are those girls that are just, it takes them some effort to get up and move, and they kind of just waddle across the pen as they're walking towards you. They come and eat, but they kind of nibble at their feet. They don't eat aggressively like the others in the pen. If we treat at this stage, it is our best option for being able to get them pulled back out of this. As it progresses without treatment, they go into late stage where they're down, they're recumbent, they can't get up. They have opisthotonus, which is stargazing. They're just sitting there with their head arched all the way back. Their blood pH drops, and eventually they can die from this disease. Dr. Mangini did a really nice job in her presentation of going through all the treatment options. We're not going to do that for time-wise today, but again, another good opportunity to go back and review treatment options in that presentation. Instead, what we're going to focus on is the diagnosis and the prevention via the use of blood metabolites that give us an indication of energy status. So plenty of literature out there talking about the use of non-esterified fatty acids or NEFAs as a predictor of future pregnancy toxemia. It is more accurate as a predictor, but unfortunately, it requires sensitive lab equipment and submission to a reference laboratory to get a result. So it's not very practical for using as an immediate answer on the farm. Instead, what we use is beta hydroxybutyrate or BHBA. This is also a blood metabolite. It's a volatile fatty acid. It's the most abundant one that is produced. So of the ketone bodies that are produced, it's in the highest quantity, which is why most of the meters that are used for goat side testing are directed towards this VFA. There are multiple different options that have been validated for use in both cattle and sheep and goats. They're inexpensive, they're fast, and they can be done with a small amount, just a couple drops of blood on farm. So that's why we recommend them instead. As a diagnosis of pregnancy toxemia, what we're looking for is a BHBA result that is over 2 millimoles per liter is diagnostic for pregnancy toxemia, especially when combined with those clinical signs that I previously described. We have ranges on here that are suggestive of hyperketonemia and high risk for hyperketonemia. Why is this different? You'll see different literature sources present different ranges for diagnosis, and that really revolves around how the study was designed. So the endpoint of the study, whether that was an animal that was recumbent or an animal that had lower limb swelling, depended on where they said the overall result was. Anyway, so one thing to kind of keep in mind here too, I'm not sure where we're getting the drawing on the screen. I'm sorry about that. One thing that to keep in mind here too is there are urine ketone strips that are available that you can just put in the urine stream of the doe that change color. Those are less accurate than blood. So if they are positive, that's a time to go ahead and treat. And we have research that has shown that the kids themselves also have a depression secondary to that high BHBA level that they're exposed to. They can also have low blood pH when they're born. So the babies that are born to these does are the ones that we need to keep a special eye on. They're often going to require more colostrum. They're going to require more assistance to get them going in their early days, or they'll have a higher mortality level. Our BHBA as an indicator of preg tox risk. This is where I really want to come in as the preventative help for my producers, is I really want to identify when things are headed in the wrong direction and make adjustments before they get so bad that we're into the treatment phase, right? That's where we all want to come in. So what we have started doing is spot checking about 4 to 6 weeks ahead of the onset of the kidding season. So if we're due to start February 1st with kidding, we come in January 1st and we start drawing blood. And so what I'm going to do is try to pick roughly 10 to 12 does per management group. This can be less if it's a very small group, but this number is pretty much sufficient even for a large group of does. We're going to focus on those that we know are carrying multiple fetuses or have had problems in the past because they're our highest risk girls. My theory behind it is if my high risk girls are doing fine, then my low risk ones should be too. So again, literature is a little bit variable as far as what is recommended. For me, I am looking for at 6 weeks prepartum, I want them to have a BHBA less than 0.5 millimoles per liter. I am willing to raise my tolerance for risk as we get closer to kidding. So if we're at 4 weeks pre-kidding, less than 0.7 is where I want to come in. That is does that are actually managing their energy status appropriately. If I'm coming in 4 weeks pre-kidding and I'm seeing 0.9, 1, 1.2 popping up, those are my time frames to start making those nutritional adjustments. So I may not have any clinical signs in those does yet, but their blood is telling me they're not managing their energy appropriately. So I'm bumping up their grain, I'm bumping up their hay quality. I'm doing everything I can at that point to keep them eating and getting as concentrated of nutrition as possible so they don't get to the point where now they're depressed and they're in full preg tox. Serial monitoring might actually be our best approach. So we may check every week, we may check every other week. If we have a high risk doe, we might check her again in 48 hours. Just to see that we're headed back in the right direction where those BHBAs are coming down versus continuing to elevate. So far, there has not been any research that's been published as far as a trigger point to make whole group adjustments versus individual animals. But on the dairy cattle side, when we're talking about ketosis and early lactation, we typically use a trigger point of about 15% of a group that is higher than we would like is time to make a whole group nutrition adjustment. I think that is actually appropriate based off the herds that I've worked with this in on the dairy goat side too. All right, other things we can do, continue to monitor that BCS. Don't discount protein. So a 14 to 16% protein ration, especially that has a component to bypass protein in it, helps maintain their energy levels. We can separate feeding. So those first timers versus does that have kidded multiple times, single fetus pregnancies versus multiple fetus pregnancies. We can target feeding to the individual group more closely that way. And then using that BHBA monitoring to ID at-risk does and keep monitoring them closely. All right, so we've been busting through a lot of stuff already, but we're going to switch gears now, and we're through the prepartum period, and now we have kids that are arriving on the ground, and we're looking at some resuscitation parameters. So what causes us to need to do a neonatal resuscitation in the first place? Well, things that might result in a resuscitation include risk factors like prematurity. If we have those pregnancy toxemias that we have to induce early, that can lead to the prematures, dystocias, so a difficult kidding, or if we're born in poor weather conditions and we get chilled, or mom just walks away from us. All of those kind of things can lead to the need for more stimulation and resuscitation. These are normal, it says calf because we use these for calves too, or kid parameters. So what does a happy, healthy baby look like when it's first delivered? They should be breathing on their own completely independently within 30 seconds. That should happen pretty quickly afterwards. Be able to lift your head up 3 minutes, hold your head up and sit sternal on your chest within 5 minutes. Trying to stand within 20 minutes and attempting to nurse within an absolute maximum 1 hour. Immediate assessment after delivery, if we are available and we're able to see that delivery happen, assessing that kid and seeing if they need help as soon as possible after delivery does result in better outcomes if we intervene sooner. So how do we decide who needs help and who really doesn't? Well, we've got those guidelines for what a normal kid should look like. But there's been some work that's been done with scoring systems. So anyone that's had a baby had an infant APGAR score assigned at 1 minute and 5 minutes post-birth to their child. That system actually has been very effective in human neonates to reduce mortality shortly after birth, and it's just because you have a objective way to assess those babies and get them the help that they need. So we've tried to do that on the animal side too, primarily with calves. There is nothing out there that's published for goats specifically. Mostly we're looking at what's been done with calves. The initial system was called the Vigor system, and it used these 5 categories here that are on your screen right now. But some of the criticisms of this system itself was that's a lot of categories to assess. We've got 5 categories. They all need to have a score assigned to them. We take a total score and we make decisions off that. That takes quite a bit of time actually that we could be intervening with the calf or with the kid during that period. Also, this system gave equal weight to every single one of those categories. Maybe some of those actually had more effect on the overall survivability of the neonate than others, and they were not correlated with viability equally. So Dr. Elizabeth Homorowski and her group up in Canada in 2017 published a study that was done with beef calves in order to try to identify a more simple way to assess which calves were going to be aggressive and viable and which ones were going to need more help. And what they identified was that the suckle reflex and the tongue withdrawal when pinched were most highly correlated to blood pH and blood lactate levels in those animals. So if your blood pH is low and your lactate is high, that means your blood is not perfusing your tissues very well. You're not getting oxygen around to your tissues, and those were poor prognostic indicators for survivability. Basically, the calves that had the low pH and the high lactate didn't survive like the ones that didn't. And so what they found is if they had a strong suckle reflex and good tongue withdrawal when it was pinched, those were animals that they could move on to the next one, whereas the calves that had those issues, they had to spend more time with. Same thing could apply to our goat kids too. If they're not responsive, we need to be spending more time working on them. How we do that is typically by physical or pharmaceutical means. So in our physical resuscitation, the first step is establishing an airway and ventilation. So that might mean cleaning the mouth out from mucus. It definitely means putting their body in a position where they have the least resistance to airflow going into their lungs. So that means sitting them on their chest with their neck and their front legs extended straight out in front of them and the back legs extended on either side of their body. One thing we don't do is we don't pick them up, hang them upside down and swing them back and forth anymore. It's not actually clearing fluid from their lungs. It's fluid coming from their stomach instead. What it's doing is compressing the lungs with the abdomen and the abdominal organs. So we want to keep them laying sternal and continue to stimulate them through rubbing them with towels or poking straw up their noses or things like that instead of swinging them upside down. If we are still not ventilating, there are some commercially available mechanical ventilation systems like this AmbuBag in the top picture, or these masks that have a bottle that you're actually just compressing the bottle and forcing air in through their nostrils into their lungs that way. In a pinch, you can use an OB sleeve that's filled with air over their nose and compress it down instead. Don't give mouth to mouth to kids. Unfortunately, we have some bacterial diseases that can be present even in normal births that are zoonotic. So they infect people and they cause some pretty serious diseases in people. So we never want to do mouth to mouth to kids. We want to use these mechanical ventilators instead. Last ditch effort physically is this acupuncture point called the GV26 point, where it's straight on midline between the nostrils with about a 20 to 22 gauge needle directly 90 degrees in, and that can stimulate some respiratory centers. I'm going to go pretty fast through our pharmaceutical approaches so that we can get on to colostrum, because unfortunately, everything that we do pharmaceutical, this tends to be last ditch efforts, and all of them have poor efficacy, and they're going to require you to work with your vet to have these kind of things done. One thing that's used commonly in the small animal side and used to be used more in human medicine was doxapram, hydrochloride, or dopram, because it will increase respiratory rate and partial pressure of oxygen in the blood. The reason why it's not used very much and it's controversial on the human side is it actually in human infants decreased the amount of blood that was going to their brain. So it reduced their cerebral perfusion, and obviously that itself is not great for us. And so that's why it's kind of fallen out of favor for use in our large ruminant species. And so this is something you might see your vet pull out of a toolbox, but it's not used nearly as much as it used to be. Caffeine as a stimulant is commonly used in premature infants, keeps them awake, keeps them eating. There are injectable formulations that are available for this, but they're not very practical for food animals. We don't have a great dosing scheme for it, and it can be kind of expensive. So not something that's commonly used in the immediate resuscitation. Where we tend to see this used more is with oral caffeine stimulants for babies that just aren't doing very good getting going eating after they've had their colostrum and everything. We might try some caffeine for them to kind of perk them up and get them to eat a little bit better, but very rarely used in the immediate resuscitation. Epinephrine increases heart rate. So if we have heart rates that are dropping or are less than 80 beats per minute, we will use this in combination with CPR. Again, this is a last-ditch effort, needs to be given frequently and IV. And so this is often going to be if your veterinarian's assisting with a delivery, they might try this as a last-ditch effort. But if there is not a heartbeat to begin with, it will not bring one back for you. So it's not something that we're going to use in a kid that is born without a heartbeat. It's more for those that are dropping and not making a good adjustment into the life outside the womb. For long term, and I use that in quotes because we're talking minutes to hours now versus seconds to minutes, that for long term resuscitation, we are seeing more and more identification of respiratory acidosis on the cattle side. These are calves that are born premature, the placenta detached too early, they had a dystocia, it took too long for them to be born, the umbilical cord was depressed, and so their blood pH has dropped. They are the calves that don't have the suckle reflex, don't have that tongue withdrawal. And oftentimes they just lay on their side and pant. They're not holding their head up. They're just trying to breathe for more than 30 minutes after birth. So one attempt has been made with trying to balance that blood pH by administering sodium bicarbonate IV. This is a slow delivery of a small amount of sodium bicarbonate IV to try to balance that blood pH. Something, again, you could work with your veterinarian if you're having those kids that are just not making a good adjustment into life outside the womb. Overall, what does resuscitation mean to us as producers and practitioners? Those kids and calves that need to be resuscitated have a much higher risk of failure of transfer of passive immunity. They are the passive transfer failure kids that then puts them at high risk for infections and disease later on in life. Again, the low blood pH and high lactate kids are depressed. This can be similar to, you may have seen a floppy kid syndrome due to the high lactate milk fermentation syndrome. Is older kids, they act similar to that. And so they can need some support through blood pH monitoring and treatment. And if they had a dystocia and it was difficult to deliver them, they might have a swollen neck and tongue, and they just can't get the physical suckle reflex going, or they might be painful from a delivery from rib fractures and they don't want to take deep breaths. So all of those things are things that we work together to give NSAIDs to those painful kids, to massage that tongue and to provide tube feedings instead to help get them nutrition while that swelling goes down. For all of those scenarios, that increases our risk that they're not going to get up and nurse on their own if they're nursing their dam, or they're not going to take a bottle very well and will require the need for more tube feeding for colostrum and more sustained feedings of colostrum than you typically would. Okay, so take a breath, and we're going to cover colostrum here quickly. Again, we're hitting the high points with this. To get more into the details, Jen Bentley and Robert Van Saan's presentation here from a couple years ago gets really into some nice research with this. I'm hitting mostly the high points for you today. Just a reminder that colostrum is liquid gold, right? So this is Mother Nature's, all the good things from maternal antibodies that we tend to think of, to hormones like growth factors that help with blood sugar regulation and just overall higher protein and fat content to provide those newborns with the nutrition they need in that early stage of life where they just don't have a reserve of their own. Our traditional approach to feeding colostrum has been by a volume delivered. And so we are shooting for 10 to 20% of the body weight over the first 24 hours, with the minimum of 10% of that delivered within 6 to 8 hours. So this was our traditional approach. We now can see some feeding to a total IgG content versus feeding toward a volume, but this is still an appropriate recommendation in general. It's also important to note that there is similar absorption on that IgG, whether the kid nurses it from the dam or a bottle or it's tube fed. So if this is a time is of the essence in your production system, tube fed is completely appropriate. Some of our newer research into the colostrum that's produced from the dam has shown that there are variations in breed, in parity, litter size, what prepartum nutrition was provided to the doe, how it was preserved, and for how long it was preserved. So there is no standard across the board. There's a lot of more variability here than we see on our dairy cow side, just because we've got more variability in goats in general, including in genetics. Prepartum nutrition in the does, this is a growing area of research. For dairy cows, we don't see a lot of effective prepartum nutrition on colostrum quality, but that is not true for beef cattle and for sheep. And we're starting to see that there's probably more effect on prepartum nutrition in goats than we originally realized. So just a quick little table. Whenever we're talking about colostrum, we talk about the 4 Qs: quantity, quality, quickly, and then squeaky clean. Got to use the second letter there for the Q. But there's 4 Qs to colostrum management, and I have put up there what is the current literature considered gold standards for each of those quality or each of those categories. And then what we are using as minimums currently. The quantity has an asterisk to it because there is still, jury's still out on that one as far as what your absolute minimum level is. At least one study listed a gold standard of 35 grams of IgG ingested to be protective. Others have used less than that. I tend to use an 18 to 35 range. The moral of the story being that the more intense the management, the more need there will be for antibodies, the higher intake we need. If you're using a Brix refractometer to assess your colostrum quality, we do use a slightly lower Brix value as adequate in goats. We can hit 19 and be okay there, whereas dairy cattle were higher. But regardless, the sooner you can get it into that neonate, the better for them. All right, so all of our literature is based around what our minimum IgG is in calves. That's minimum IgG for quality colostrum in cattle is 50 grams per liter. There have been at least one published study that showed goats may need to go up to 70 to 75 grams per liter. Again, we don't have the official answer here yet. We can use more research in this area, but in our limited studies, they've all been based around this same level. Because our absorption efficiency is only about 20% on average, that means only about 20% of the IgG in the colostrum is actually going to make it into the bloodstream on the kid. That's why we have to go higher in order to make up for that. Recommendations for serum IgG levels have changed dramatically over the years. In the older publications, we're talking 8 grams per liter was sufficient for protection. Most recent publications are listing even 15 plus grams per liter. So the question mark there is, how high are we going to continue to go? Again, Dr. Van Son published in 2019 at least one study that consuming 35 grams of IgG hit that 15 grams per liter level in the kids. Moral of the story is the more intense management, the more potential exposure that we have for those kids to pathogens, the more IgG they're really going to need. Doing that quality assessment on colostrum, we're all moving towards the Brix refractometer. It's going to cost you a few $100s to get set up with one of these, but they're really easy to use. They're quick and they don't take much colostrum to get a reading, which is really nice when you want to save that liquid gold for use actually in the kids. What we're looking for is a range of at least 19. Anything over 22% is going to be considered even better than good, very good. Always test before you pool. That way, if you have poor quality colostrum, it doesn't end up in the pool and diluting out that IgG. And generally speaking, the thicker it is, the better, the higher the IgG content. We want to feed this quickly. That first 6 hours of life happens to have the highest absorption efficiency. So getting it in as soon as possible as that gut closure tapers off. Dividing it into a couple feedings so that they don't have this huge glug all at once. And then continuing to feed colostrum over at least the first 24 hours. That 6 hour time frame is nice to remember because that's also the time frame that you want to milk out the doe within that time. So after that 6 hour time frame, she is now producing milk, and so she's diluting what's in the udder pretty quickly. So milk out the doe within 6 hours, feed the kid within 6 hours. All of our squeaky clean guidelines are based on research in calves. We are lucky when it comes to our small ruminants that having those pelleted feces actually helps keep things much cleaner for us than we have with the cattle scenario. And so this is kind of more of a reminder to not just think about the doe's udder and her body itself, but also the milker's hands, the milking equipment, the containers that you're putting it into when you have collected it. All of those, if they have bacterial contamination, will reduce the absorption of colostrum. On the cattle side, we heat treat colostrum to kill things like yonis and just overall bacterial counts in the colostrum. On the goat side, we're also using this for CAE control. So on the lower end of the temperature spectrum for CAE control is heat treatment at 133 degrees for 1 hour. Current recommendations in cattle have gone up to 140 degrees for 1 hour for a better bacterial kill there. Can do that in our goats. We got to be a little more careful with that temperature though, because if we go over that 140 or extend the time period, instead of heat treating that colostrum and just killing the bacteria, we're starting to denature the antibodies. Denatured antibodies don't work very well to begin with. And the other thing is it turns your beautiful colostrum into more like pudding. So feeding it is not proper either. And so when we're talking about high Brix readings above 25%, those are colostrum production that is more likely to do that denaturing and become pudding. So we stay on the lower end of that temperature spectrum. There's lots of different ways to do this, from commercial equipment to a double water bath to sous vides, all those kind of things. The biggest thing is you got to monitor it. That time starts when the temperature hits the 133 degrees, not when you initially put that colostrum into the cooker to get it warming up. If we are having issues, or every so often, especially on our bigger scenarios, we will do some culturing post-heat treatment or of thawed colostrum in order to make sure that our bacterial counts are staying down where they need to be. Unfortunately, we're not very good at detecting actual virus from CAE in that colostrum through PCRs or things like that. Cool it and store it immediately. Always use a deep freezer, not one that goes through freeze-thaw cycles. The frost-free freezers are not your friend. If you are a large producer and you are putting multiple bottles into the freezer at one time, consider the volume that you have going in. A lot of warm colostrum coming out of heat treatment can raise your temperature in your freezer significantly for several hours after it's placed. And so that's a time for bacteria to grow. So if you are stacking that freezer completely full, you might want to have another option to cool and freeze so you're not overworking the freezer itself. Always remember, don't microwave it when you're thawing it out. That denatures the proteins that are in there, and then don't leave it out on the counter for hours. Again, just a reminder on the raising CAE-free kids, when you're feeding that heat-treated colostrum, we're killing the virus, we're not denaturing mom's antibodies that have been produced against it. So those kids that are fed heat-treated colostrum will still test positive on your serologic tests for several months after they receive that colostrum. So keep that in mind when you're designing testing programs with your vet. Just a couple thoughts on colostrum itself, right? So dam colostrum or farm source colostrum is our gold standard because it has IgG directed specifically to the pathogens we have on the farm, but sometimes it's not available. Sometimes it's not practical in the middle of the night to have to milk a doe, heat treat colostrum, feed the kid, get up an hour later and go back to work, you know? And so we do use some colostrum replacers, an alternate source colostrum in some situations. If you're using colostrum from a different farm, like a dairy, cattle dairy farm, keep in mind that we do have a dilution effect in cows, so there's a much larger volume, so lower IgG concentration per volume. That might mean that when the kid's full, he's still not getting enough IgG ingested. Things like colostrum replacers, they are absorbed at the same efficiency as the maternal colostrum antibody, even though all of them are bovine colostrum or bovine serum IgG based, it's still absorbed the same. How long those antibodies last and how specific they are to what's on your farm is a good question. So if you're having given the choice of using a dried colostrum product versus a serum-based product, they are not the same. So the colostrum-based products have not just IgG in them, but they're also going to have those maternal cells. They're going to have the protein and the energy levels that you're looking for. The serum-based products tend to be using more whey or vegetable-based fats and proteins as their energy sources, which are not as digestible. So keep in mind that you get what you pay for when it comes to these, and you always want to use a replacer product, not something that says a supplement, always a replacer. I put up here a couple replacer products. I'm not going to tell you which one is which because this is an example of products that are bovine based, marketed to goats, that have issues with the feeding volumes to them, right? So you can use calf products that are marketed towards calves, right? So you can use a calf labeled product. You're just going to basically take, for the most part, 150 to 200 grams of IgG for one calf will cover 3 to 4 goat kids instead. But when we're looking at different products and we're calculating how much IgG we're actually getting out of them, it's important to do the math on how much they're getting as mixed. So product A here is a very commonly marketed product for kids and lambs. It is 15 grams of IgG and 8 ounces of powder. So when we mix it according to the label directions, it's telling us to mix about 2 ounces of powder in 8 ounces of water. That is going to give us about 6 to 12 grams of IgG fed over the 24 hours if you follow the feeding recommendations. So we're only getting 6 to 12 grams out of their feeding recommendations. I kind of put up there earlier, 18 being the minimum that I'm shooting for. That costs $12 per bag. I can feed 2 kids on that bag based off of their recommendations. So $6 per kid doesn't sound so bad, right? But are we really getting enough bang for our buck there? It's a good question. Contrast that to product B, which is a calf product, but it has 200 grams of IgG in 750 grams of powder. So you got almost 4 times as much IgG per gram of powder there, and it's mixed in a smaller amount of water. So if we are feeding it by body weight, like we talked about earlier, a 7-pound kid, we get about 10 ounces of this as mixed colostrum in that first feeding. And that gives them a whopping 25 grams in one feeding there instead. And so as I look at these in comparison, yes, Product B is more expensive, but I am getting so much more bang for my buck. I'm getting enough colostrum. I should say what we think is going to be enough colostrum. Plus, I'm doing that in one feeding instead of multiple feedings. I can continue to give more after this. Again, colostrum replacers are all bovine based. They're absorbed the same. What the question mark is right now is how long those antibodies last in the kid over time, how fast they degrade. For me personally, I would love to have the farm source colostrum as the gold standard, but I also completely understand the middle of the night scenario or even during a busy day. And the biggest thing is getting colostrum into those babies. How do we know if we're doing a good job with our colostrum control to begin with? If we're going to assess our passive transfer, the most common way that we do this is with our serum total solids. There are reference laboratories that you can submit for total IgG counts to, but the easiest way to do it is by drawing a blood sample when they're 2 to 7 days old and looking for the total protein in that blood or the total solids in that blood. Caveats to this are they have to be adequately hydrated. If the kid is dehydrated to begin with, that's going to falsely elevate that total protein. So you want them to be adequately hydrated. You want those kids that are doing well, bouncing, happy, healthy. If they're not, we're going to make some other assessments with that too. Generally, we're looking to sample 10 to 12 kids in that week's time frame with the goal that at least 80% of them will have met that standard of at least 5.5 grams. 6 would be better of total protein. On the dairy cattle side, just recently, there's a position statement that has been published with new guidelines for passive transfer of immunity in dairy calves, and it breaks it down by excellent, good, fair, and poor levels. And so on a farm basis, we're looking for at least 40% of the calves that are sampled to have a serum total protein that is an adequate level of above 6 to 6.2, correlating to a Brix percentage of greater than 9.4. And then it goes down by 10% for each category after that. Again, we have not validated this for goat kids yet, but it appears to be a good starting point, at least for farms, to kind of assess where they're at. Regardless, no matter how many times I present this, I will have somebody that comes up to me afterwards and says, you know what, we were always thinking that our kids had too low of total protein, so we started adding more colostrum and we ended up having more problems. These are general guidelines as a starting place for evaluation of the farm, but ultimately there are farm-specific effects and genetic effects across the board that need to be further investigated. And in the end, and these are guidelines to give you a place to start from to determine what works on your farm. So with that, I will open up to any questions. We are running right on an hour already. There's a lot of stuff to cover and a lot of topics. I appreciate your attention today. I'll open up if there's any questions.
Well, thanks, Dr. Friedrich, for all the great information. I know you provided a lot of information, and I also did reference some of those videos, YouTube videos that we recorded in the last couple of years, if people want to go back and refer to those. And I'll do a follow-up email with our participants with those links as well in case they can't get them here. But we did have a couple questions come into the chat, and I think the first one was on the BHBA levels. Are those ranges different in sheep?
Pretty similar for ewes too. Yes. I use the same reference ranges regardless, sheep and goats. They
Okay.
are lower than what you're used to if you have cattle. Most of the time we will go up to 1.4 millimoles as subclinical ketosis in cows. So if you also have a dairy cow herd and you're looking at BHBAs in early lactation for ketosis there, our tolerance levels are lower for sheep and goats.
All right. And People can go ahead and put their questions into the chat if they still have some. Again, another reminder, I did put the evaluation link in for today's webinar, if people wouldn't mind clicking on that before they leave here today, so we get an idea of our webinar series as we move through the year. That is very helpful to our extension work. I know Lester did have a question here, just kind of more random question, is is it also safe to use bovine colostrum in human children? So I know we use bovine colostrum for goat or for yeah, for our dairy goat kids, but
So that's a very good question. And unfortunately, as a veterinarian, legally, I can't provide you any advice that way. It's outside of our practice act and our scope. I do know that if you are active on any kind of social media, that there's a lot of people themselves. You can get on Amazon and buy bovine colostrum supplements. And there are people that are considering it for gut health in themselves. Yes, we have had people reach out to us as a veterinary practice asking for the same thing. Ultimately, that's a question for pediatrics. Unfortunately, as a vet, there's not an answer that I can provide for that. Mhm.
thanks. And I think Lester, you had raised your hand. Did you want to unmute and ask a question as well?
All clear. Got it answered. Thank you.
Okay, sounds good. And it looks like there was another maybe comment for those who use colostrum replacer. The kids will not get any benefit from CD and T vaccination. So when should those kids get a vaccine shot?
That's a very good question. And I'm glad that you brought that up. That is something that I missed on that presentation of that slide, right? And so yes, when we're feeding dam colostrum and we're doing the heat treatment and everything, we're vaccinating the does to protect the kids. When they're using a replacer, we have no guarantee of exactly what antibodies are included in that colostrum replacer. So for the CD&T product alone, so we're talking just CD&T, the vast majority of those that are on the market are polysaccharide-based vaccines. So they can be processed and safe to use in very young kids. On average, we're probably somewhere around 1 to 3 weeks old when we give that first dose there. I do have a couple herds that we go as young as day 3 for that initial dose because they are not getting CDT from their dam, protection from their dam. Now, if you have a reason to use an 8 or 9-way clostridial product, like you have other clostridial diseases besides tetanus and enterotoxemia as concerns, those are whole cell and they have different adjuvants with them. So they are really more safe for 3 and 4 week old kids and plus. And so we oftentimes end up using more antibody related products like antitoxins. Anybody that's a vet that's on the call or has used those in the past is all sitting there going, ugh, with me, because there's very few producers for those products anymore, and they can be very difficult for us to get. So some of the other things we can do for prevention on the enterotoxemia side involve milk feeding, mixing appropriately at the right temperature and feeding freshly mixed milk, trying to prevent them from over consuming that. So we're keeping those carbohydrates digesting in the abomasum instead of going down into the small intestine.
Thanks. And we had another question come in about using the bricks for testing goat colostrum. They test immediately postpartum and they often see levels at 38 or higher. So is there a too high of a level?
No, there isn't, but sometimes you actually have to dilute your colostrum, and that's actually Dr. Van Son has some good work with sheep, especially if you do sheep, that they can be high enough to where they feel that their readings are not as accurate when they get really, really high. So they'll dilute it 50-50 with saline and run their bricks that way and then back calculate for the total IgG that's in that. I just look at that. If you're getting 38s, man, congratulations, right? Like you got some real liquid gold for sure.
As kind of a follow-up to that question about using the bricks, I know you mentioned the digital bricks, but if somebody wanted to just get into it and used a manual bricks, is that an option, or due to the fat level content? Is it just going to be kind of
I would,
harder to
I,
read?
I think I would save up the pennies and go for the digital bricks, right? Because not only does it do, it's such a small volume. It's really nice. They're very handy. They're they're easy to use. We routinely bring vet students in on day one and go, here's samples, run them, and don't worry about a lot of user error with it. The other bonus to the digital bricks is they will also run oftentimes your serum total solids for you too. Like they run multiple different modalities, and so you can use them for more than one thing that way. So I think if it was me personally, I would go for save up the money and buy the digital one instead of the manual, even though it's lower cost.
Thanks. I have one other question. I don't, if I'm not seeing any in the chat here yet, but so I know in dairy cattle, we have seen some research on heat stress and the effects that it has on calves as well as colostrum quality. Any of
Mhm.
that translate to does and dairy goat kids?
It's a very good question. Jury's still out on
Okay.
that. Unfortunately, we have such limited data right now. I presented this at the ADGA meeting last fall. Immediately after the presentation, I had 4 or 5 people with things that were different from what was in the presentation that worked for them, right? And so that is the hard part about this is on the dairy cattle side, we have decades of colostrum research. We have put a ton of money into that and research wise. On the dairy goat side, we're very limited with our numbers, and we have quite a bit more genetic variation in our dairy goats than we do on our dairy cattle populations in the US at least, overall. And so what I have had in conversation with some of the leading researchers in this area and reading their publications, there probably is an effect to it. There's also an effect just with the prepartum nutrition. We may see more effect in the dairy goats with prepartum nutrition just because we have more changes that we can make versus our dairy cattle, where we tend to be very, very tightly regulated anymore on our nutrition. I think that's why my beef cows do better when I up their nutritional quality in prepartum period, is because they were probably marginal to begin with. There's more of an incremental impact versus my dairy cow that was eating really, really good to begin with. So yes, I would say heat stress times. One of the bigger questions for us in Iowa this last few weeks has been, what does cold stress have to do on that? When it's 30 degrees below zero, we're not just worried about teat end damage from frostbite, but they're putting more energy into just maintaining themselves, not making colostrum. So significant long cold stress snaps could definitely have an effect.
And it looks like John just had a follow-up to the C&D vaccine, same 2 ml dose for young ND kid.
Yep. I know it's a lot on a tiny baby. I don't have all vaccines run off the concept of a minimum immunizing dose. So when they're licensed, they all have a minimum level of antigen that was included in that vaccine that was shown to be protective in a lab situation against a challenge, whether that's a virus or a bacteria. Then beyond that, they add additional antigen in order to keep it at that minimum level throughout the entire dating period and so on and so forth. And so there is somewhere less than 2 cc's there that is going to be effective, but we only those folks that work for that company and have that insider knowledge could tell you exactly where that limit is. And so I can't say for sure that 1 cc is going to be protective, right? I can say that 2 was in those scenarios. So from our standpoint, we're still recommending the 2 cc doses. Not all products are created equal. Work with your veterinarian on what they prefer as far as which ones provide them the best protection without the most side effects, right? Because our biggest risk side effect wise on those injections is injection site reactions, lumps and bumps that develop. And some of them cause less of that than others. So talk to your vet about that one.
And I guess just for clarification for others on the call, ND would be Nigerian dwarf, correct?
Yeah.
Okay. In case we don't have colostrum, how can we make substitute by normal milk?
Unfortunately, there is no good substitute for colostrum. Normal milk for energy levels, yes. But as far as the antibodies that are included in the immune protection, there really isn't a substitute. The only other option I have as a vet there is to do a blood or a plasma transfusion for that kid to supply them with antibodies that way. And so that is one of the areas where I like the option of a replacer product, right? So even though the doe and her colostrum is our gold standard, sometimes that's just not there. She isn't making any. The doe dies. Random things happen, right? And so if you can get one of those powdered products that is shelf stable, you don't even have to use the whole bag. So if one bag feeds 4 kids, you can measure out the weight that is a quarter of a bag, and you can just mix that part up and save the rest of it in your freezer until you need to use more. So I really highly recommend for my clients that they keep something on hand in case something happens, right? Because our Tysons and places like that and your vet clinics aren't always open when when it's 2 o'clock in the morning. So having that on hand so you have it ready to go before you start the kidding season is very important, because there just really is not a substitute for colostrum.
And I guess one last final comment here from Teacup Farm. They also use the Atajo, if I said that right, digital bricks that they can export that data for record keeping. So I think that's really neat that they can
Nice.
export that and track that over time. That'd be kind of interesting to see performance of kids based on level of quality of colostrum too.
Yeah, that's amazing. Thank you for putting that into the comments for us too, because yeah, you might even, especially if you're following the recommendation to test individual colostrum before you're pooling, right? You may see a familial relationship there where there you have some lines of some genetic lines that produce really, really well and others that don't as much. Can be a selection criteria. Yeah.
All right. Well, I think we came to the end of our questions here. We probably could go on all afternoon if you had the time, but we're gonna respect your time here this afternoon and appreciate you giving the information here. And I think if people have follow-up questions, they could always reach out to you or get a hold of our extension team. We do have an email. You could email us at dairy goats extension. I'm going to type it in the chat here at iastate.edu. If you have any questions, there's a whole group of us that are on that email that we can help answer questions as well. So thanks for joining us, and we look forward to seeing you back in March. Thanks again.